Hello, and welcome to tonight's Immunisation Coalition webinar. The topic tonight is on COVID-19, a disease update. My name is Andrew Minton. I'm the CEO of the Immunisation Coalition. It's really my pleasure to be your moderator this evening. Now, I haven't done this for a little while, so I'm a little bit rusty, so we'll see how it goes. Now, I'd just like to recite the acknowledgement to country before we start and acknowledge the traditional custodians of the various lands of which we work today and all Aboriginal and Torres Strait Islander peoples that may be participating in this webinar tonight. So welcome. I pay my respects to elders past, present and emerging, and in particular the Gadigal people of the Sydney area which I reside. And to celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands, the animals, and waters of Australia. So, before I introduce tonight's guest speaker, who is Professor Gary Groman, Gary will be speaking for about 40 minutes. I just want to let everyone know that there is plenty of time for questions. We should allow about 15 minutes for those. If we don't get to all of the questions, we will provide a transcript with the answers, together with a link with the recording in about a week's time. So if you miss anything, we'll be able to provide that information for you. Now, just a bit of housekeeping. If you could ask your questions through the Q&A chat function at the bottom of your screen. If you could try and make the questions short and try to avoid acronyms or abbreviations, just in case I don't know what they are, that'd be great. And I'll try and get through as many questions as possible. Tonight's presentation will be recorded, as I said, but so therefore all participants will be on mute. And we're expecting a good turnout tonight. We have several hundred registrations, so we're at 165 and climbing. I think there's a bit of a renewed interest in COVID-19. So we've had so much on RSV, and in fact, we had a webinar last night on maternal vaccination and infant immunization. So that's just one of many that have been presented over the last few months. So with COVID-19, look, it continues to evolve, and Professor Groman will talk to that. It's still out there, it's still evolving, it's still infecting many Australians, particularly those aged 75 years and older, and those in aged care. And there's still hospitalisation numbers that are too high, and there's also too many unnecessary deaths. So it hasn't been forgotten. It's out there, it's real, and it's timely to talk about it as we head into the flu season. So just introducing our guest speaker tonight, Professor Gary Groman. Gary is a board member and a director of the Immunisation Coalition, and is also a member of the Immunisation Coalition Scientific Advisory Committee. He is an adjunct professor at the University of Sydney and is a former head of immunology at the TGA. Gary is a virologist and a consultant for the WHO and also environmental pathogens, which is in Canberra. His interests include, as a virologist, virology, vaccination and control of infectious diseases, pandemic planning, particularly with COVID and influenza, environmental public health issues, regulatory advice, vaccine development, and vaccine manufacture. So with that, I'd like to introduce Gary to take us through his topic of COVID-19, and we really look forward to what he presents tonight. Thank you, Gary.
I think I'm sharing now. Is that right, Andrew?
Yes, I can see that's perfect.
Okay. Well, firstly, a warm welcome to everyone. And thank you to the Immunisation Coalition for asking me to provide this update. A few disclosures there, particularly some advisory roles to a number of companies and groups that I wanted to declare. These are not paid roles, but ones that I'm on various advisory boards or with committees. So what do we see? We see with COVID-19, the current landscape in Australia, we see as of mid-June 2025 that Australia is experiencing a significant increase in COVID-19 cases. It has been described as a surge in the press and so on, but that's just simply not true, and I'll show you why later. We have seen the emergence of new subvariants, particularly NB 1.8.1 and PF2, but these will almost certainly be overtaken by XFG, and I'll show you some data on that as well. And the fact is that most of these mutations or changes in the S protein have little or no impact on the virus properties, although people do talk about it becoming more infectious and so on, but that's hardly true. It's very difficult to measure, particularly when it first comes out and suddenly you find a claim in the press or from an epidemiologist that it's suddenly more infectious. So NB 1.8.1 was a predominant strain in several regions in Australia, particularly in May and early June, and Queensland showed the greatest number of cases. And between mid-May and early June, we saw a 64% rise. Hospitalisations also surged, so to speak, over 320 people admitted in the past 2 weeks, 2/3 of whom are over the age of 65. And since January 2025, Queensland in particular has suffered, and we've seen over 17,000 cases there and 3,000 hospitalisations. But it's not really a surge. If you look at the blue graph here, you see it's much lower than previous years. And yes, there's been an increase, and that's to be expected over the winter period. So annual numbers and cumulative numbers are far below those of previous years. We've also seen co-circulation with other respiratory viruses. I think there might have been a missed slide. Apologies for that. So the current situation nationally is that the situation mirrors what's happening in Queensland. Australian Respiratory Surveillance Reports indicates this increase in COVID cases all over the country. So far, cumulatively, we've seen a total of 12 million cases that are confirmed, clearly an underestimate, but that's the number we have, and 25,000, almost 26,000 deaths, and that's a far more accurate number. Also, the numbers of vaccines distributed is over 71 million doses, and unfortunately, there is a number who have not had a vaccine in the last 6 months, 17 million people of us, in fact. And that's a bit of a pity because it shows that we have a suboptimal uptake, particularly in the more vulnerable groups, and I'll show you some data on that as well. And with hospitalisations, you can see that Queensland leads the way, but the numbers are increasing in the other states as well. So we also have co-circulation with flu and RSV, and this should not be forgotten about. We really have this sort of three-pronged attack, and probably human metapneumoviruses as well. I don't have data for Australia, but in the UK, it's 5% of cases for that virus, 7.8% in China, just to give two examples where we do have data. So we do get this simultaneous rise, but influenza is the one that has caused the most number of cases, and the same RSV has also increased by 28%. And in Queensland, a 30% increase compared to the previous year. And the RSV program was launched in April 2024. We heard a bit about that already. And since its inception, over 57,000 women and children have been immunised, which is estimated to have led to a 75% reduction in RSV-related illness. And it's just an important point to highlight that vaccination does work. And it's very, very important, particularly for flu and RSV, to bring those case numbers and hospitalisations down. So getting back to COVID, we've seen the Omicron variant 1.8.1 dominate. It's a subvariant that's characterized by a broader range of acute symptoms, in particular nausea, vomiting, diarrhea, heartburn, but it has the usual common respiratory symptoms. There is no evidence of increased severity, and the current JN1 COVID vaccines are effective. And what we saw in May, if we look at data here from GizAid, in blue, you see a new virus appearing, XFG, and 1.8.1, which started to dominate, particularly in May. And these were the groups that were dominating in May, and then 1.8.1 was dominating in June, and now in July, we see almost equal numbers dominating. And here, again, in blue, XFG, and 1.8.1 there in pink. So those two subvariants will knock out all the others, and these two will dominate for a while, and one of them will undoubtedly continue, and then another one will again arise. We do need to stop catastrophizing every single subvariant that arises until we actually move to the next major variant, which I presume will be called Pi. Then we really don't need to worry too much about the constant appearance of new viruses due to point mutation. Now, ATAGI, one significant thing that has happened is that ATAGI and ACIP have made more or less the same recommendations, and that hasn't happened for some time. So COVID vaccinations are no longer recommended for healthy children and adolescents under 18. So that's a significant change, and that's in the Australian Immunisation Handbook. So a few quotes there: COVID vaccine is not recommended, and this is because of the risk of severe illness is extremely low in this particular cohort. So there's no point in vaccinating at this time. ATAGI has also made a number of specific recommendations, which are important to note. So they recommend COVID-19 vaccine every 6 months for high-risk groups. That includes older adults and those with underlying health conditions. So we've known that already. But despite these recommendations, vaccination rates remain particularly low, and that's prompted health officials to urge eligible individuals to stay up to date. It's not easy reading the ATAGI documents, I have to admit. Even I struggle with it because a lot of it is ambiguous, and it's difficult to interpret for most people. But I've just put this table together, which is based on an ATAGI table. Firstly, it's important to understand that effectiveness against mortality is 70 to 78%, but this wanes after 8 to 12 weeks. So this is not an optimal vaccine, but it will give protection for around about 3 months. And if that's timed well during the winter peaks or whenever the virus is surging, then people that are vulnerable will have protection. So it is recommended for the over 75s. And for those that are severe compromised, the 65 to 74 group, it's recommended once a year. And then they have this strange phrase, can consider, which seems like somebody sitting on the fence and then nobody knows what to recommend or advise patients. Then the 18 to 64 group, recommend every 12 months, again, to consider. 5 to 17, if immunocompromised, again, can consider, but I would read it as not recommended, not recommended, not recommended, not recommended for under 18. So without severe compromise, then it's really only recommended for the over 75 and 60 to 74 group. It's not even recommended, but just consider for the 18 to 64. So the landscape is changing. Also, I wonder if this group should be 50 to 74 rather than 65. And I'll show you some data to show you that it's really the over 50 group that are the most vulnerable in the community. But ATAGI have made some other specific recommendations that are worth reiterating. Firstly, women who are pregnant or breastfeeding. So unvaccinated pregnant women are recommended to receive the vaccine. Vaccinated pregnant women are not recommended to receive further doses if they've already had a shot. And there's an NIH study in pregnant women, which concerns a lot of people, but there's no need. It says there are no safety concerns for COVID-19 vaccination during pregnancy, but if you look at this slide here, the vaccines have actually not been formally studied in pregnant women. Nevertheless, ATAGI and other groups around the world consider it safe for use. So medical conditions where it is recommended, there's a whole list there that we're probably fairly familiar with, and I won't go through them. Basically any immunocompromising condition, any serious disease, including obesity and diabetes. And they also make the point that co-administration of the vaccine with other vaccines is possible and should be encouraged. So it's possible to have a COVID plus a flu or COVID plus an RSV together, and they remind us that all vaccinations must be recorded on the AIR. So what vaccines are available in Australia? Well, it's actually only the Pfizer vaccine, the mRNA vaccine. There are pediatric formulations under 5 and under 12, and there's an adolescent and adult formulation for over 12. We did have the Novavax recombinant protein formulation in Australia for some time. That's being updated and still undergoing the registration process with the TGA, and I'm not sure when it will actually be on the market, but hopefully it will be with us later this year. It is actually important to have alternatives in case supply chains go down, and also some people prefer not to have mRNA and prefer the protein vaccine. But there's a lot of activity going on in terms of clinical trials, but you see nearly all of them are revolving around either protein subunit or RNA or mRNA or RNA vaccines. And there's lots and lots of other approaches as well, but these are the two that really have shot to the fore and are being researched around the world and in fact being used and are registered. Self-amplifying messenger RNA is a new novel vaccine that will come on the market. It's already registered in Japan. In very simple terms, it's a self-replicating synthetic messenger RNA that leads simply to more protein antigen and therefore a better or amplified immune response. So we look forward to seeing the data on that in Japan, and then I'm sure it will be before the TGA and FDA in due course. And that's a product being produced by CSL and Arcturus. So safety and immunogenicity of a parainfluenza virus type 5 vectored COVID vaccine is also of interest. So that's got very, very good data from a phase 1 clinical trial. The safety data is excellent. There are no serious reactions. The serum and mucosal immune responses are very good, and it's genetically stable. So this is yet another approach that people are looking at, just published and in Science Advances. And it looks really quite excellent because of the range of serum and mucosal immune responses that it will achieve. Of course, all vaccines have side effects, and there are very common minor side effects like headache, fever, fatigue, and muscle pain. These perhaps only last a few days, but occasionally there are serious and very rare side effects, but I emphasize they are very rare. Anaphylaxis, GB syndrome, myocarditis, and pericarditis have all been described. And as we know, for myocarditis and pericarditis, it tends to affect young men under the age of 30 more than any other group. So if we just look at it a little more specifically for the mRNA, we get this usual list of side effects that are fairly minor, including loss of appetite, fatigue, fever, muscle pain. Anaphylaxis is really rare, around 10 per million doses. Myocarditis is also very rare, and it's probably 1 in 100,000 or maybe 1 in a million, depending on the data you read. And the highest incidence has been reported in adolescent males after the second dose of an mRNA vaccine. If you look at the Nuvaxoid, the Novavax product, it has a very similar profile in terms, although maybe slightly less, in terms of adverse reactions that are acceptable. In terms of anaphylaxis, the rate is actually undetermined, but it's almost certainly less than 10 per million. And myocarditis and pericarditis does occur. Again, it's very rare, like the mRNA vaccine products. And if anything, there's a slightly higher rate of pericarditis than there is myocarditis. But again, I emphasize these are incredibly rare. We look at anaphylaxis. This obviously, if anyone has anaphylaxis, then it's a contraindication to get another mRNA vaccine or protein vaccine. And we see that polyethylene glycol is probably the cause of anaphylaxis in the mRNAs, and polysorbate 80 is probably the cause of anaphylaxis, and again, very few people with the protein product. So there has been this interesting report just published this year on the effects of mRNA vaccines on the corneal endothelium. I'll just take you to the last 2 points, actually. So there are changes in the corneal endothelium. These occur in the short term after 2 doses of a Pfizer vaccine. And the conclusion basically is to monitor this carefully, that the endothelium should be closely monitored in those with a low endothelial count or those who have had a corneal graft. Now, I don't think this is a serious adverse reaction, but it's a very interesting observation. It does need to be repeated. The work they did looking at the central corneal thickness was significant. So it needs to be followed up and repeated, and it would be of interest to patients that have had a corneal graft. They might need to be monitored a bit more closely. But as a big reminder, vaccines have dramatically altered the course of the pandemic, particularly for older adults. We've seen this in clinical trials and real-world studies, and there's no question that these have been highly effective at preventing severe disease and death. That can almost not be quantitated, but we know it's been tremendous. And like most vaccines, there's always been this terrific benefit, which often gets overlooked. So even though vaccine efficacy is slightly reduced in older adults compared to younger populations, the benefit remains substantial. And I might also add that the AstraZeneca vaccine was also very effective. Yes, there were 13 deaths associated with the vaccine due to blood clots, but they, in my view, could have been avoided if there had been proper education to the public who received this particular vaccine. The epidemiology hasn't particularly changed. We know it's spread by respiratory droplets. It can be spread by fomites. The R numbers 5 to 6. The virus highly labile, easily destroyed, even just simply by washing hands. Masks are incredibly effective if used properly. We also know that Sweden was less effective than most comparable countries that implemented much stricter lockdown measures and other measures. And we know that hygiene measures and isolation was particularly effective, especially early on in the pandemic. And excess deaths per 100,000 are interesting reading, very high in Russia, India, USA, UK, and Sweden much lower. And these countries, these first 5 countries, were dealing with alpha, beta, gamma, delta, whereas we in Australia, we have a lower number of excess deaths, but we were mainly dealing with Omicron and some delta. So it was a different proposition. So it wasn't surprising. We also had very strict lockdown for some time there that also reduced the death rate. So even with not doing anything, Sweden did much better than the UK, USA, India, and Russia. I like showing this slide. We see in Australia the number of deaths early on in the pandemic and then starting to increase with 5 or 6 waves over time. Vaccines were rolled out in February 22. This is a period of strict lockdown. And when they lifted the restrictions, all these cases went up despite the fact that we had a very good vaccine program. And it just shows you how important these hygiene measures and isolation procedures are. They're very, very important to help slow down the virus, halt the virus in some circumstances like a closed community setting. And we needed simply more vaccines, but people weren't prepared to get more than 2 or 3 boosters. The over 50s are an important group. We know in Australia, 5,000 people died in 2023, 3,000 people died nearly 4,000 people in 2024, and 159 to date in 2025. Where are those deaths? They're in the over 50 group, basically. You could argue for an over 45, but I've drawn the line at over 50 because that's the vast majority of deaths in men and women. And it's this group here that's our major risk group. And this is a group we need to focus on in terms of getting people boosters. And that's a really important bit of data, I think, that's come out of the Australian Institute of Health and Welfare. And that's the group we need to focus on, not just people over 65 or 85, as has been suggested before. Even if we look at World Health Organization data with COVID deaths, we see there's a jump in that 15 to 64 group. And I did look at this data a bit more closely, and it's basically 50 to 64. And then, of course, you get a significant jump in the over 65. US data from CDC showed the same thing, just slightly different approach, but they showed that the risk of death from COVID increases markedly with age, particularly after 50. So they concluded that individuals aged 50 to 64 are 3 times more likely to die of COVID than those aged 18 to 29. Those from 65 to 74 are 6 times more likely, and the risk of hospitalisation follows a similar pattern, which makes age a central element in risk stratification strategies. So we know in the over 50s, it's had a disproportionate impact on older adults. We assume immunosenescence is at play. They represent a group with heightened vulnerability to both infection and severe outcomes, including hospitalisation and ICU and death. Aging and high prevalence of chronic diseases in older populations almost certainly plays a part, and other diseases which are more common in the over 50s, like cardiovascular, diabetes, obesity, COPD, renal impairment, and so on, are all more common in those over 50, and that must also play a role. So I think it's important for this group to consider getting regular vaccinations. So the burden among older adults is even worse. In aged care settings, we saw considerable mortality, particularly when Delta was around. This was highlighted by the Royal Commission, which reviewed COVID, approach to COVID in Australia. But despite high vaccination uptake among older adults, we still have these challenges of waning immunity and variant escape, and also a laziness in vaccinating older adults that are institutionalised. So deaths in aged care facilities have hardly changed. 29% of all COVID-related deaths occur among people living in residential aged care. More than 200 aged care facilities right now are facing active COVID-19 outbreaks. That's right now, that's this week. And if we look at a graph from Australian Institute of Health and Welfare, in purple you see deaths in aged care centres and cases in this grey colour. But you see the cases the deaths rather hardly changed in July 23, January 24, July 24. They've dropped a little bit now, but we're just not vaccinating people enough in those particular settings. And that's shown in this slide of aged care vaccination, 55%. We don't do well with our Aboriginal and Torres Strait Islander peoples either. These are age-specific death rates per 100,000. In Indigenous people, 459. In non-Indigenous, 322. So again, we haven't managed to vaccinate them enough, or they've refused it, or they've certainly not received it for some reason. We haven't done well in the NDIS either. 6.6% have been vaccinated in the last 12 months. That really is pathetic, and such a pity, because it means there will be more illness, severe illness, possible hospitalisation and death as well. The same thing with individuals with culturally and linguistically diverse backgrounds. CILD, 3.1%, 2.1%. This really is very bad reading, and we're not targeting the risk groups enough. So we can now talk about COVID as higher risk settings and higher risk groups. And for higher risk settings, it's obvious, it's residential aged care, disability, in-home aged and health care, hospitals, other healthcare, First Nations, and CILD. And high-risk groups, aged over 50 is the main one. Those with weakened immune systems, neurological disease, lung disease, heart disease, obesity, diabetes, and chronic kidney disease are the highest of the risk groups. Not necessarily in that order. The clinical course we know that the virus is excreted here before the onset of symptoms, which is so typical of any viral infection. So there's excretion in the pre-symptomatic phase. And then we have innate and cellular immune responses. Depending on how strong they are or specific they are, we will either get a mild disease or end up with severe disease. And that just depends on the person. We have PCR tests, which are highly sensitive, and we have RAT tests as well. I'll get back to them. During this pre-symptomatic phase, we can use antivirals, we can use immunoglobulins, we can use prophylactic antibodies and therapeutic antibodies at different stages of the disease. And of course, many of these people can have significant sequelae. Many have poor neutralizing antibody wanes after 10, 12 weeks, leading to reinfection. And then, of course, we can get long COVID or post-COVID syndrome. The rat tests have always interested me. People ask me, how sensitive are they? Well, if PCRs are 100%, the most rat tests are about 86%. That's pooled sensitivity for pre and post approval studies. So while manufacturers claim 90 whatever percent, the reality is probably about 86%. And the FDA has done a study and shown that 79% of FDA approved rat tests lack post approval studies. So there's an onus on companies to keep testing their product to make sure that it is sensitive compared to PCR and change it if necessary. So we can also look for symptoms. The symptoms are generally the symptoms of COVID are indistinguishable, flu and other similar viruses. But there are a number of important emergency warning signs for COVID-19, even in the absence of diagnosis, like trouble breathing, persistent pain or pressure in the chest, new confusion, inability to wake or stay awake, pale, grey or blue-coloured skin, lips or nail beds, just depending on the skin tone. And for children, you get this MIS-C. It's this unusual presentation, similar to Kawasaki disease. It's very rare, but again, the symptoms are clear: hypertension, non-purulent conjunctivitis, polymorphic rash, mucosal changes, and swollen extremities. A good reminder, SARS is a neurotropic virus. Some 10 to 15% of patients develop acute neurologic symptoms. It's associated with specific neurological symptoms, can lead to stroke and other disorders, or encephalitis and meningitis as well. So less frequently, we see peripheral nerve involvement, such as muscle weakness or GBS. The clinical symptoms can be quite severe. We can get multifocal pathogenesis, we can get cytokine storm, I'm sure we're all familiar with these, and then patients with pre-existing neuromuscular conditions, these can be exacerbated and lead to autoimmune conditions and GBS. And in some cases, viruses, latent viruses or chronic viruses can also be reactivated. The herpes group, you might get outbreaks of shingles, for example, herpes simplex, CMV. The enterovirus group and human T-cell leukemia viruses have all been described as reactivating during severe clinical symptoms. There's been recent work done on disorders of the gut-brain, DGBIs. These conditions basically include IBS, dyspepsia, chronic idiopathic constipation, and COVID can also commonly cause diarrhea, nausea, abdominal pain, which can lead to IBS. Then there's the issue of psychological stress, which is also a significant factor through lockdowns, fear, and isolation. And there was a surge in IBS. I'm not sure about Australia, but there certainly was in the USA from May 21 through to May 22, and that's now been reported by Elmiro recently. And IBS prevalence rose from 6.1% in May 2020 to 11% in May 22. That's in that particular study. We've also seen that SARS-CoV-2 might induce Alzheimer's disease. Got interested in this papers, but I want to stress this is only an in vitro study, but it's a very interesting one where they've been able to show amyloid extracellular protein aggregating in human retinal explants and retinal organoids. So this suggests that the spike-1 protein during infection with SARS-CoV-2 or COVID can induce this amyloid beta aggregation. And that might explain a lot of the neurological symptoms associated with COVID-19, including something as simple as brain fog. So that one, I think, is a matter of watching this space to see what in vivo studies can be done to prove this or otherwise. There are, of course, complications and sequelae of COVID-19, and we call that post-COVID condition or long COVID. It has a difficult definition. It's clearly a range of various disorders and sequelae. But while it's not well defined, it does continue for more than 3 months. So that's something that has been defined after the onset of illness without an alternative explanation. And there are various symptoms, as I'm sure we know, from fatigue through to cognitive symptoms, psychological symptoms, pain, and so on are all described. It's highly variable, but 45% of survivors of COVID-19 experience a range of unresolved symptoms at about 4 months, but the long COVID burden substantially reduces after 7 months, and even more so at 9 months, depending on the data you look at. But it seems to me to be about 9 months. Risk factors for post-COVID condition may include the presence of comorbidities, and in particular, prior hospitalisation from COVID-19, being of the female sex, being an older age, having a high BMI, and smoking are all related in some way as risk factors for long COVID. And vaccinated people, interestingly, have a significantly lower risk of post-COVID condition. And there have been studies done with that too. It's one of the reasons the US kept up vaccination even in children for so long, but now that's been dropped. It's simply virus persistence causing chronic inflammation, immune dysfunction, microthrombosis, affecting all organs of the body, in fact, particularly brain, lung, cardiovascular, and GI. There are inflammatory biomarkers, for example, interleukin-6, C-reactive protein, TNF, and this basically is a reasonable set of core blood biomarkers that can be used to diagnose and manage long COVID patients. This interesting evidence from MEARS studies, which have identified complement activation as being involved, and the treatment of complement activation might be a path forward in treating long COVID. Studies done of long COVID in children quite recently, published in JAMA, and it's common in the USA, to my surprise, affecting up to 10% to 20% of children. We don't really see this here. So there must be other factors involved. Over 6 million US children were affected, and earlier CDC studies going some years back showed that only 1% of children went on to long COVID. So there's a bit of a disparity there, 1% and then suddenly 10%. So that will be of interest to see how that goes and what might come from those studies. They have produced an interesting fact sheet here. So signs and symptoms of long COVID, children in various age groups, for infants and toddlers, for school-aged children, preschool children, and adolescents. And when you look through them, they're all slightly different. And it's this kind of infographic that can be used to help diagnosing long COVID in children. I won't go through all the details here, but there's a good reference to it. And of course, the slide will be available. So, how do you unravel the interplay between respiratory disease and the immune landscape of long COVID? And the answer comes down to this. Long-term dysregulation after infection underlies many of the persistent symptoms of individuals with long COVID. And again, it's quite a good paper if you want to read it up. What are the treatment options? The management of COVID requires timely diagnosis and prompt intervention to prevent this progression to more severe disease. Antiviral agents such as Paxlovid, Molnupiravir are really useful in reducing the length of time in hospital. These medications are particularly beneficial for older adults and those with comorbidities. Of course, hospitalized patients have other treatment options in addition, like the use of corticosteroids, antivirals like remdesivir, depending on the severity of illness, IL-6 inhibitors have all been used. The issue that TGA points out rather well is you need to be careful of interactions with other drugs and potential side effects. So that needs to be monitored very carefully. Telehealth has emerged. I'm sure GPs listening to this might think it's good and bad. There are advantages and disadvantages, but it seems to be quite a vital tool during periods of high transmission to help monitor symptoms and adjust treatment remotely while reducing exposure risks. Molnupiravir and Paxlovid are both used. They're excellent for reducing all-cause mortality. Molnupiravir is more readily available for adults. Paxlovid, not authorized for children under 12. Molnupiravir is not authorized for children younger than 18. And it's not Molnupiravir, that is, not recommended for pregnant individuals either, because animal studies suggest it could cause fetal harm. Well, where are we now? The COVID global health emergency is over. There's no doubt about that. That's been declared by WHO. So we're dealing with a steady state respiratory infection in the community. And the virus itself has been mutating over time to less severity. So we now have quite a number of asymptomatic and mild infections rather than the more severe ones. And Omicron lineage viruses are predominating globally. And as I mentioned before, there's no need to catastrophize every appearance of Omicron at least. So vaccines are available and important for those people over 75 and those that are immunocompromised. We've seen the rise of hybrid immunity. That's people that are vaccinated together with natural infection. Antiviral drugs are available. Home testing kits are available. In Australia, we would still expect 1,000 to 2,000 people to die annually from COVID-19, but that risk is declining, and the major risk is in homes for the elderly. We need a continued focus on protecting individuals. This is imperative. We still need continued vaccination campaigns, which have waned terribly, I think. We still need to educate our community, particularly against vaccine hesitancy and misinformation, which has really hurt the COVID and other vaccine programs. We need early access to antivirals. This is important. We need diagnosis and get the antivirals into people straight away. We need non-pharmaceutical interventions. There's nothing wrong with wearing a mask, particularly for somebody over 50 who might feel a bit uncomfortable in a shopping centre or an aeroplane. I think that should be encouraged. And we need these integrated health services, of course, coordinated care models that address chronic disease management alongside COVID-19 surveillance. And this will help reduce the overall burden in older adults, and mental health support, which has been clearly identified. So a few conclusions before I stop. People over 50 face significantly higher risk of illness and death from COVID-19, not only in Australia but globally. This group has clearly borne a disproportionate burden of the pandemic. Vaccination still remains a cornerstone of prevention. We could add antiviral drugs to that, I think. Access to effective antiviral treatment and adherence to public health guidelines will clearly mitigate risk and save lives. And continued vigilance, tailored health interventions, targeted communication strategies are all essential to protect the vulnerable in the community. It will continue, COVID, there's no doubt. It will be diminished somewhat by vaccine uptake, but it won't stop. Waning immunity will almost allow it to continue, but we also have suboptimal vaccines. We need vaccines not to wane after, not antibody not to wane after 10 to 12 weeks. We need antibody to be for at least 6 months with newer and better vaccines. Virus mutation does lead to new variants, so it has immune escape potential, but we probably only need to update, this is my own personal assessment, update the vaccine at the moment every 12 to 18 months. And there are seasonal factors involved when it comes to COVID spread, like travel. And when people come to Australia, say in our summer, from their winter in the Northern Hemisphere, then new viruses will be coming into the country as well and reseeding our population and vice versa. Obviously, we have a lot of challenges remaining, and I don't have enough time to talk about any of these in detail, but about 10% of people are going to get long COVID in Australia. We have a community blasé attitude to booster vaccinations, which is resulting in low vaccine uptake. We've had tremendous damage done to various programs and economies. We've had vaccine injury that's being addressed. We had mandates, which really should never have happened. We've had job income losses, and because of all this, there are class actions now going on, which is unfortunate. There's a problem with vaccine fatigue, distrust, fear, and disinformation, but the fear is caused by the disinformation in general, and that's a pity for not only COVID, but all vaccine programs. And ultimately, we need better vaccines. We need better and more available antiviral drugs and other drugs that will help. So just wanted to thank various sources of information and open up for questions. Thank you, Andrew.
Thanks, Gary. Very comprehensive overview, specifically on the different subvariants and SARS-CoV-2 lineages and infection rates, and specifically the infection rates in the individuals over 75 and in aged care and the death rate. So the death rates are still there. They're not as high as they were last year and the year before. And when I do look at some of the infection rates from the NDSS, it's quite different from looking at the over 75s and over 85s from 2023 for the first two quarters, because I'll compare it to the first two quarters of this year. So in the over 85s, over 80 and 85s, it was 5% infection rate for 2023, and 2024 it was 13% of the population. And in 2025 it was also 13%, so steady. But the infection rates are dropping, but as a proportion of infections, it's still high in the older populations, which reside mostly in aged care. And the death rate is predominantly, I think, from aged care as well. So I did read a report in February, which was distributed by Department of Health, Disabilities and Aging, and they showed the COVID-19 vaccination rates in aged care across all of the aged care facilities in Australia. And they were showing that many of the aged care facilities were at either 100% vaccination rate or less than 10%. But the way that they showed it was, I think, a little bit misleading, because it was residents of the aged care facility who could be linked to their vaccination record. So it wasn't really representative of all of the aged care residents. So my question to you, Gary, is: are we failing aged care residents with vaccination rates? Because
Oh,
that's where
absolutely.
most of the deaths are occurring.
Yeah, no, absolutely. We've got less than 50% of people in aged care that have had a vaccine in the last 6 months. In some centres, the last 12 months. That's a terrible statistic and really needs to be addressed by those involved with aged care centres, doctors and nurses and so on. It's very, very important to keep for that particular group or people in any closed community setting, no matter what it is, to have regular vaccines. And it's not just COVID, of course, it's a variety of vaccines. The fact is that people carry COVID and other viruses, some clinically. And so they will easily pass it on to the people that they're caring for without realizing it. So it's particularly important that people in those closed community settings get vaccines, and also the staff attending those patients should also be vaccinated. They can't be mandated, but they should really consider it.
Yeah, and I was talking to the chief medical officer not so long ago at the CDIC, and was talking about a pilot study that we did recently. I won't name the state, um, and there really should be vaccine coordinators in each aged care facility that are coordinating uh, um, with the provider to come in and vaccinate the residents after getting consent. And we were looking at a model to see if it could be one or two providers that come in and vaccinate en masse, but we just couldn't get enough aged care facilities to sign up for it because they were just so busy. So maybe we can just simplify it and cut through a lot of things and just go through direct to the aged care facility, uh, fund them appropriately for them to coordinate the consents, and with a one or two provider model to come in and vaccinate, and not only COVID, but influenza, pneumococcal, and maybe whooping cough at the same time. There are quite a few questions, so sorry, I'll get through them here. Um, yeah, look, there's a lot of vaccine fatigue around. How do we motivate people to get vaccinated? So, very difficult question to answer, but I'll put it out there.
Look, I think it's up to those in the front line, the GPs and nurses, the pharmacists, the doctors involved, administrators, anybody working in hospitals or close community settings, be the role model for vaccination, for goodness sakes. There's been so much disinformation out there that people believe, even well educated people, and that's such a pity. We can only follow the science. And the science tells us very, very clearly that even though we do have some imperfect vaccines, particularly with respiratory viruses, they nevertheless work. And it's really important to combine that with antivirals, with proper procedures in those various settings. But we have to be the role models. Don't believe social media and don't believe someone who says, oh, this has to be true. Just remember, I get a bit annoyed at social media because these people have either got minimal or no qualifications or no experience, and none of them take responsibility. Absolutely none of them. It's you people out there looking after patients that take responsibility. And they will listen to you. Patients will listen to you. And I've been trying to get that message over to various groups. No matter who you are in the health area, be the role model for vaccines. And if you have a doubt about vaccines, then fine, express it. I'm happy to answer your questions. I can see one here in the chat about a book, Dissolving Illusions. I've not read that book, but I assure you it'll be an illusion itself. I've yet to meet or read or see any evidence for any of this kind of disinformation or this nonsense on social media that people believe just because somebody's an MD, PhD, or MBBS or whatever. And these people take no responsibility. Let's stick to the science and well-crafted studies that, if possible, are well controlled. And it will never be perfect, but we're doing very, very well. In Australia, we've been probably the most successful country in controlling COVID to this point anyway, and through the pandemic. I don't think we realise that. And our strategies were excellent from initial isolation and stopping planes coming in and so on to the use of vaccine, antivirals, and education. It may not have been perfect, but was one of the best in the world. And I would just encourage everyone to be the role model. So that's my answer to that. I see there's some comment here about the old chestnut of ivermectin and hydroxychloroquine. Please don't believe this stuff. It's not repeatable. They're simply silly observational studies. You might as well associate some data with the weather. That's about the sort of plausibility it's got, and it makes no sense. And there is no mechanism of action. That's the other wonderful thing about people who say, try drug X or drug Y. Tell me the mechanism of action and I'll think about it. But nobody can tell me the mechanism of action. And no one in the TGA or elsewhere in science, scientifically based, are going to register something that has no mechanism of action. This is, again, this is all part of this whole disinformation nonsense that affects the whole community. I'd encourage everyone out there to stick with the science and stick with public health edicts and the CDC and the WHO and so on that follow the real science. We all know it's imperfect and we all know it's evolving, but we've never made a claim without data. Whereas all these other people, from ivermectin to hydroxychloroquine to any other drug, whatever they're peddling, the various snake oils out there have made claims and take no responsibility for it. So
Right.
sorry to be a bit hot under the collar about it, but it's time. It really is time in the medical and scientific community that we started to fight back from this stuff. It really is.
Well, there's plenty of evidence that the best recommendation is from a healthcare professional. So the healthcare professionals are doing a very good job. But also we can look at it from the other end to provide um, public-friendly disease education to inform them and provide factual, trustworthy information. So we can work from both ends to try and convince the public that vaccination is a health benefit. So there's a question here around what's the current recommendation for a booster dose once you've had the COVID-19 infection? What's the time after that to receive your booster?
Oh, you need to wait at least 12 weeks.
Okay.
And then
What about here? I wrote it down. Vaccination during pregnancy, recommendations for single pregnancy, but no further doses. Does that apply to multiple pregnancies?
no, just the that particular pregnancy. So if there's been a vaccination during pregnancy, then there's no need for a second one.
Okay. Um, Among those eligible for antiviral, commencing a script within 5 days or medication within 5 days of symptoms, um, is that the right course?
Yeah, look, what really is within 24 hours, if possible, like any antiviral drug, you need to get it early. Remember, the peak virus replication is going to be before the onset of symptoms. So ideally, you would do a rat test or PCR, get a diagnosis, um, get a script, and then go off, fill that script, and start taking the drugs. Uh, we don't do that well, and people get a bit lazy and think they've got something else, so they don't do a rat test or get a test from a GP. It's quite important. I mean, the rat tests, I think, have been incredibly successful because you can immediately go to your doctor as a patient and get an appropriate script. But you do need, particularly when it comes to Paxlovid, you do need the management of your GP, and patients should be told this because people over 50 in particular might be on various drugs which may have interactions with Paxlovid. So that needs to be looked at carefully by healthcare professionals.
Your thoughts on patients being asked to do a rat test or a rat prior to being offered a GP appointment? What are your thoughts on that?
I don't see any harm in it. I think it's a fine thing. Uh, we need to use these rat tests, but they also need to be better. If they're only 86% effective or sorry, sensitive compared to PCR, then we need better rat tests. If possible, they should be in the 90s as the companies claim, but that's not the case.
So you're from Canberra. I looked at one of your slides. It said percent of aged care residents vaccinated to the 11th of June for this year. The national was 48%, ACT is 55%, and all the other states and territories are below that. Um, I've looked at influenza vaccination rates and other vaccination rates in ACT. What is it specific with ACT that have consistently higher vaccination rates than the national average and almost all other states and territories? Is it just geographical confinement?
Uh, I think with the ACT, you people are this is a hard one to put. People are have I think there's an average of 2.2 degrees or something per person. The workforce generally is better educated, so they're going to be better educated when it comes to vaccines and so on, and seeing their GP and getting better medical treatment and so on. So it's a question again of education. Uh, People that have more education in general will keep their health up to date. They'll keep their car servicing up to date. They'll pay their bills on time and so on and so forth. So Canberra is truly a bit of a bubble in that respect. There's no question. It doesn't have the wide variety of socio-economic um, groups that other cities have. So I think that's an important thing to take into account. So the ACT in particular, yeah, it's got a 98% vaccination rate to nearly every vaccine. It's been incredibly successful with childhood vaccines and so on. It's a smaller group, a target audience. I don't know that the advertising is any better, but certainly people see their GPs more. And I think that's a big factor, seeing your healthcare worker.
We should take a look at that because Queensland has consistently the lowest vaccination rates across a number of disease areas, even though, for example, influenza is free for 7 months of the year. Just because something's free doesn't mean to say people go
No,
out and get it for
thing of
sure.
being free, in my view anyway, the thing of being free is interesting, but people will go, educated people will go because they know that vaccines will protect them from severe disease. They may not be perfect, but they will protect them. And of course, you'll always have an anti-vax group, and we respect those people as well and their views. Uh, but they're not based on science, that's all. They're based on a view or an opinion or a feeling, whatever it might be. But ultimately, vaccines help the whole community, even those that don't get vaccinated, as we know.
Maybe just another one or two more questions. Does it make practical sense, and this came up before, to combine a COVID-19 vaccine with another vaccine? What are some of the complexities to consider if you were to combine it with influenza, which influenza changes each year? Is that realistic, or should we just focus on programs that get jabs and arms with the vaccines that we have?
Absolutely. This has been looked at by various research groups and companies. So ideally, with mRNA, in theory, you could combine flu, RSV, and COVID all together. There are studies going on in Queensland right now looking at that with mRNA vaccines. It's the same with recombinant proteins. You could do the same thing. So these are theoretically possible, but we need to do the clinical studies, not only for adverse events, but to see how the immune system reacts. And we also need a wide variety of studies because they may react differently in a healthy person compared to somebody who has an underlying disease. They may react differently or perform differently, I should say, in children and adolescents than they do in adults and they do in the older age group. And you'd expect that to some degree, just from a biological point of view. So these things are underway, but whether they'll actually be used in due course, we don't know, but that's certainly the aim, to have a combined vaccine for, say, flu and COVID or flu and RSV or flu and HMPV. Any of these things, these studies, two of these studies at least, are going on in Queensland right now.
Okay, I think we just run out of time, unfortunately. There are a number of questions I couldn't get to, but we will provide answers to those questions and we'll provide those out in a week's time together with the link to the video. So you will receive your answers to your questions. I'd just like to thank Gary for a really fantastic overview and for the audience for their engagement as well. The next webinar that we have is on, we're going to take a break for August, well-deserved breaks. It's been very busy in the last couple of months with CDIC and so forth. That's on pertussis on the 17th of September. We may do a pneumococcal disease in September and October. That's yet to be determined. That's the Alan Cripps Memorial pneumococcal disease. And just a flag for our third primary care infectious disease meeting on the 25th of October. That's not on our website at the moment, but we're hoping for, we're aiming for a third of GPs, a third of nurses, and a third of pharmacists on site. And then online, it can be whoever. So we're going to make it a primary care infectious diseases meeting, which is a little different from what we had in the previous two meetings. So I'd just like to wrap up and thank everybody again. There will be a short survey that will be sent to you. If you have the time to fill it out, that'd be great. We're always looking to improve the way that we conduct our education. So from myself, a big thank you to everybody. Stay safe, stay well. Gary, you might want to say goodbye, and thank you very much.
Thank you.